Hello everyone, welcome to Osteo Momentum. In this video, we will discuss how to quickly assess shoulder pain in a clinical setting. Let's get started. When a patient entering our clinic with the complaints of shoulder pain, we often doesn't have much time to conduct a long and detailed assessment, right? That's why a quick and structured evaluation is necessary. How we can evaluate very quickly? We divide our approach of thought that into three parts: muscle, nerve, and bone. For the muscular aspect, we identify that which muscle is tenderness is present or not, which muscle is tight, and which muscle is weak. For that, we have to reach out a proper diagnosis chart through the proper evaluation. So these things you guys are not miss out while observing while evaluating the shoulder, while assessing the shoulder. So next is moving to bony part. Bony part also palpation, abnormality, crepitus, and malfunctioning. So this also helpful for to evaluate and also differentially diagnosing the part if there is any fracture present or not, or any AC joint dysfunction or not. So we have to rule out very easily through this. Next is the nerve involvement. That is, quickly we do upper limb tension test to rule out the nerve easily. Then the step for core assessment part: observation, palpation, and evaluation. While observation for shoulder aspect, anteriorly, we mainly focusing if there is any ACL dysfunction is there, fountain sign, step of deformity, and sulcus sign. If the patient have ACL dysfunction, their clavicle is prominent and also prominent while doing horizontal abduction and adduction. Step up deformity is also present, and also assessing the level of shoulder. Okay, on posterior aspect, level of shoulder, spinoscapula, winging of scapula, spurling deformity, and Lenni's test. You guys, these two things never miss up for to assessing the shoulder. The posterior aspect of assessing scapula also. Okay, then next for to palpation part. For to palpation, anterior aspect, we mainly focus suprasternal notch, SC joint, clavicle, acromioclavicular joint, acromion process, greater tuberosity of humerus, coracoid process, and bicipital groove. These things for to palpating bony aspect on anterior. Firstly, suprasternal notch, patient position is sitting, and while using the therapist's index and middle finger to palpating the triangular notch between the clavicle. Okay, that is suprasternal notch. We have to palpate that triangular area between two clavicle. Next is sternoclavicular joint. This is easily palpating. Instruct the patient to shrug the shoulder. Instruct the patient to shrug the shoulder. Thereby, we can easily palpate that sternoclavicular joint. Then next is the clavicle. By moving the fingers laterally from the sternoclavicular joint, we have to palpate clavicle. If there is any increasing in prominence, crepitus, pain, that's the evidence of fracture. So the level of clavicle we have to palpate by this. Next is the acromioclavicular joint. Easy for to palpating the acromioclavicular joint, that is, instruct the patient to extending the shoulder. Instruct the patient to extending the shoulder. Then laterally to palpate acromion process. Okay, acromion process. Here we can see acromioclavicular joint and also acromion process. Next is mainly focusing onto the bicipital groove and also greater tuberosity. That's also palpated while we assessing the shoulder. This mainly helpful for to identify that which part is more affected, and we have to rule out and the conditions and to reach out a diagnosis part very easily. Then on to the posterior aspect. Moving on to the posterior aspect, we mainly to assess the level of scapula. Okay, level of scapula, borders of scapula, medial border, and the angles of scapula, and the superior border, inferior border, and also the spine of scapula. We don't miss out these things while assessing the shoulder also. Okay, next is Lenni's test. Lenni's test is mainly helpful for to identify that the scapula is symmetrical or not. Firstly, we have to palpating the T2. We have to palpating T2 and to mark that point, and to from there we have to measure using a inch tube to superior aspect of the scapula and compare with the dominant and non-dominant side. From the same way, we palpate T2, T4 and T8 and compare with dominant and non-dominant side. From this, we have to identify that the scapula is prominent or symmetrical or not. Then next is winging of scapula. Classical winging, rotatory, dynamic and static. For classical winging, the medial border is outwards, they are moving outwards. At the rest time also they are moving outwards. This mainly occur due to serratus anterior nerve palsy. Okay. Next is the rotatory winging. For rotatory winging, inferior angle of any one of the scapula, they are moving outward. Any one of the scapula, they are moving outward. That is rotatory winging. Then next is the dynamic winging. For dynamic winging, there are two types there, medial winging and lateral winging. Medial winging, its name, it also says that they are medially winging. That's mainly occur due to long thoracic nerve palsy and serratus anterior is affected. That is medial winging. Here serratus anterior muscle supplied by the that which nerve, long thoracic nerve. Okay, long thoracic nerve, that is medial winging. Medially scapula is moving, that is mainly occurring for the medial winging. Then next on to the lateral winging. Lateral winging means that its name already says it, that means laterally the scapula moving. It's supplied with spinal accessory nerve is mainly affected with trapezius muscle palsy. Okay, trapezius muscle palsy. So while assessing the shoulder, we mainly assess these things also, trapezius muscles and scapular muscles, everything. Okay, we will cover the parts here, and the muscle and nerve assessment is on to the next video, inshallah. Okay, I hope you enjoy and understand today's video. Drop your thoughts and suggestions in the comments below. Don't forget to like, share and subscribe to Osteo Momentum for to quick and evaluation assessment part. Okay guys, thanks for watching.